We're now going to just focus on the ethical aspects of gender affirming care. And as I've said earlier, I really see our providing care for transgender people as the next frontier. And if we look at over the last, say, 100 years, where as a society we are slowly trying to become more inclusive. So only about 100 years ago in South Africa, white women got the vote. 30 years ago in South Africa, democracy, where actual people of color was finally included. We've had same-sex marriages since about 2006, and then the inclusion of trans people in terms of being depathologized only literally in the last decade. And so we are literally sort of progressing slowly as a human society, becoming more and more inclusive. And so for me, transgender people, it's not just about the specific community, but also about us as a society. And so I'm going to cover some of this little philosophical um, issues around when we start thinking around ethics, because not all kinds of societies have ethics. And I think it's helpful to just take a step back. And I'm going to focus a little bit on something called the Wheel of Power and Privilege. Some of you might have come across this. It's used quite a lot in the refugee world. And the idea is that some people within the world have certain unearned privileges that puts them closer to the center of power. And others, due to unearned, again, disadvantages, are sitting further away from the center of power. And with the center of power, I mean your ability to change what happens in your own life and to change what happens in the society around you. So, how much power do you have as an individual to actually make things different in your life and in the world? And these kinds of households that we get born into, the kinds of bodies we get born into, is outside of our control. And in the world of today, it's becoming this, there's a real polarization in these two different ways of thinking about society. So the one way is what we call an elitist society, and it's very much the way the human beings, the way we've been rolling for the last a few thousand years. And it's very much based on our survival self. So as human beings, we do have a bit of a survival of the fittest that goes on as we're also part of the animal kingdoms. And if you are an elitist, then you would have an underlying belief, or you would have a value that some human beings have more value than others. Some people are just more important. And the people who decide who those people are those with power. So if you're closer to the center of power, then you get to decide what kinds of people are acceptable and what kinds of people are not acceptable. And these people in power will then create systems of classification. And whenever we talk about marginalization, discrimination, and oppression, it has to talk with those sitting in the center of power, making those decisions. In a society like this, the more of these unearned disadvantages you have, the more these intersect, the more vulnerable you become, and the less power you have to actually make a difference in your society. And if you look at, for example, what's happening in America at the moment with people of color, those that are undocumented, those that are trans, intersex, or non-binary, those that are poor, those that have got neurodiversity, those that are lesbian, bi, or asexual, all of those kinds of intersections at the moment is very in America, they slowly some of their rights and some of their access to services is being taken away. So a different way of looking at the world, and as I've mentioned, actually a rather more recent way of looking at the world is an egalitarian view. And this is a more abstract view that we can have as human beings, because it hasn't got to do with our survival emotional self, but it actually has to do with our more intelligent part of ourselves that starts thinking wider about what are we as a society and what do we want to be as human beings. And an egalitarian view believes that all human beings have equal value. And it recognizes that we live in a society where some have more power and some have less power. And we start asking questions about how do we create a society in where everybody has value and therefore also have access to resources and rights. So those two types of views of the world, the two different ways of looking at the world through either an elitist or egalitarian view, builds two different types of societies. So the hierarchical society is how we've always run. This is the way the world pretty much has always worked. It's based on that elitist principle that some people are more valuable than others, and it's always a pyramid. So in the old days, you would have had your king at the top and your dukes and your duchesses, or you'll have a chief at the top and the sort of the powerful underneath them. And then you'll always have particular groups of people that sits at the bottom of that pyramid and has the least access to power and to resources. Important to realize is that capitalism very much falls into that pyramid. So although one can have democracies, which are sort of starting to think about an egalitarian view, the reality is as soon as you put a capitalism financial system into a country, you immediately end up back with one of these hierarchical societies where those with money in the world at the moment, all the billionaires have all the power to decide what's going to happen. And if you have no money, or if you've got very little money, then you actually have extremely vulnerable in the societies that we currently live in. So this is one of the contradictions also in the world that we are in. What is emerging slowly in the last, literally also just in the last century, is this idea of an equalitarian society. And that's based on egalitarian principles. And now we start using these words. We use words like diversity, where we recognize differences. We talk about equality and equity. So the equity very much speaks to that circle, understanding that somebody who sits on the margins of that circle actually has got much less power, and therefore we need to create opportunities for people sitting on the margins and creating a place for everyone within our society. And whenever we talk about democracy, liberalism, human rights, we are within this sphere. This is a new sphere, and it is actually, in terms of human development and evolution, it seems to be much more vulnerable than I had thought only a year ago. And currently in the USA, which was sort of been the defender of this concept of diversity, equality, equity, and we can now see how within a few months it's actually turned into an authoritarian state. What's interesting to notice is that ethical principles, when we talk about ethics, are always a product of an egalitarian paradigm. As soon as you will use a thing like the word autonomy, you are certainly talking in terms of DEI, for example. And so obviously this particular training that we are doing is very much coming from an egalitarian paradigm. So it's useful to understand and to remember that TGD is a very marginalized population. So I've mentioned these unearned disadvantages and unearned advantages, and as they intersect, where they intersect, that becomes very vulnerable. So our transgender people in themselves are very marginalized. They're a very small community, very poorly understood community. But also if you intersect that, for example, if they are poor, if they're a person of color, and imagine also if they might be undocumented, there's quite a large association between being autistic and being transgender. So quite a large percentage of, or larger than the neurotypical population of, there's a larger population of neurodivergent people versus neurotypical people that are gender diverse. And if these things start intersecting, we actually find a population that is extremely vulnerable within the world that we live in. So we're not going to spend time on this because we're not in a nice, lovely, interactive section. This is the kind of things that's lovely to sit and talk about. But just for a moment to just look at yourself and think a little bit, and just look, these are some of the things we've picked out in that middle circle that puts you automatically closer to the center of power. If you are male, if you are white, if you are what we call cisgendered, if you are a citizen or English speaking, if you have a executive level, or you're a professional high up in your field, if you're educated, which I think almost everybody here is, able-bodied, if you're a bit older, heterosexual, all of these things automatically give you much more power. And you can already think about, we're not always aware of the rewards and the privileges we get just because of these particular unearned advantages. And so it's very good to reflect on what makes it more difficult for those people that are sitting upon the margins from these particular identities that you embody. So the challenge is that for trans and gender diverse people, this unequal distribution of power and privilege means barriers. It means barriers to healthcare. It means barriers to education. It means barriers to employment. It means barriers about safety. It's kind of interesting that you've got all these cisgender people fighting about bathrooms, but the only people who get attacked, not the only, but the people who get attacked in bathrooms, if you're talking transgender versus cisgenders, transgender people are the ones who are getting persecuted in bathrooms, certainly not cisgender people. So when cisgender people talk about safety in bathrooms, it's actually taking away the safety of our trans people in those spaces. But what's frustrating is in the world that we live in, such, for example, Trump, cisgendered male, white, able-bodied, middle class, these people have extraordinary power in the world to make decisions about what should happen with trans bodies and trans healthcare. What's also interesting is that within trans spaces, of course, there's also variations and privileges. So if you've got a transgender person who's, for example, educated, white, rich, they also will have very different experiences than somebody who may not maybe severely disadvantaged. So let's move on a little bit about ethics. So ethics, we talk about a set of moral principles, beliefs, and values. And as I've said, these are always invested in this egalitarian view. So our moral principles here is based on the belief that all human beings matter and all human beings have value. And the values that actually inform these ethical principles is and what we're going to look at specifically today. Oh, and there's something interesting that's happened to my citation down at the bottom. Apologies for that. That's from the WHO document on ethics. But there's the Yoga Carta principles. So that's a set of humanitarian principles South Africa have signed up to. That's particularly around reproductive and sexual health rights. And within that, it has this, everyone has the right to bodily and mental integrity, autonomy, and self-determination. We talk about person-centered care in South Africa. So we've got a strong Ubuntu that forms part of our view of how we view patients. And then the HPSA ethical guidelines very strongly have respect for persons and human rights embedded in that. So these are the documents that we are drawing on when we talk about ethics. The South African HIV guideline actually is very much an egalitarian document, obviously, and very much includes those ethical principles and has very strong ethical values as part of that guideline. So let's just go through the classic 4 that is specifically used within the medical field when we talk about autonomy, beneficence, non-maleficence, etc. And then when we talk about autonomy, it's always interesting that when one talks about autonomy and freedom of expression, it's just important to realize that there's also what I call opinion equity. And although everybody says we should all have the freedom of expression and we all should be able to say what we think, so if I hate trans people, I should be able to say so. But actually freedom of expression, because of that power circle we talked about, is not an equal playing field. So if somebody I mentioned earlier that Helen Ziller is unfortunately very much anti-trans and very much fixated on this binary, and she carries an extraordinary amount of power within her party and also now within our government. So her ability to affect the lives of transgender, her opinions, has a much bigger effect on what happens within, for example, trans healthcare. But conversely, if a transgender person or even transgender advocacy organization speaks out against cisgendered people, they have absolutely no chance in affecting the lives of cisgender people. They're not going to be able to take away any of a cisgendered person's rights, for example. So we talk about this freedom of speech versus freedom of reach. And so actually freedom of speech without ethics, without considering this autonomy and value of other people, that is actually what we mean with hate speech. And that is why there's such an urgent need to also update our laws around hate speech, which within it actually has protections for people to still persecute others, for example, if it's part of their religious beliefs. So the HPSA ethical guidelines speaks very strongly about autonomy. So we should honor the rights of our patients to self-determine and make their own informed choices. And so all of our medicine is based on that. The patient makes a choice. We just make sure we've given them all the information and they take the responsibility for their decisions. If there is a scenario where your personal beliefs is going to prejudice your patient's healthcare and their particular whatever your beliefs clash with their beliefs, and therefore you cannot provide that kind of care, then it's very clear that we must then inform the patient that actually I'm not able to help you, and then we have to refer them to see another healthcare practitioner that is able to provide that care. So again, you also have a right to autonomy and self-determination, and we saw that, for example, with the Termination of Pregnancy Act. So you as a healthcare worker can decide whether you want to engage or not. But if you do not, then you have to refer and make it possible for somebody to access services somewhere else. So it's interesting if you look at there's different kinds of threats when we look at the whole LGBTQIA plus community, but with the transgender community, it's a very specific kind of threat that's slightly different than we find with the other letters within the LGBTQIA plus. And because the current way, the way that transgender people or the way the anti-trans movement is operating is trying to deny their autonomy. So it's saying, no, your experiences is not valid, is not real, does not exist, does not fit into what we think the world should look like. And therefore, you do not have the right to ask for pronouns, to wear certain clothes, to receive hormone therapy, etc. So this intervention of trying to stop gender affirming healthcare is is actually directly affecting autonomy. So we are advocating for the autonomy of transgender people to receive the care that they are requesting. When autonomy is not respected, what that looks like is what we're seeing at the moment in the UK and the USA, where they, for example, have decided that there are only two biological sexes. That's also problematic for people who are intersex. And this is very similar into the race classification of the apartheid government. So arbitrarily classifying groups and deciding which groups are valid or not valid. And what is becoming concerning, especially in the USA, is that then this idea of transgenderism, it gets called a thing, and it's been literally framed as a threat that needs to be eradicated. And that's very similar to what we, for example, saw under the Nazi reign. So when we talk about gender affirming healthcare, we've actually moved away from what was traditionally called a gatekeeping model under these sort of a decade or 2 decades ago, and we're now very much working under the HPCSA ethical guidelines of informed consent. So a gatekeeping model was basically the healthcare worker now had to decide whether somebody was trans enough. And therefore also the healthcare worker now carried this terrible burden about what's going to happen. And, I make this decision on whether I'm going to give hormones or not. And if it doesn't work out, then it's all my fault. But we're very much moving away from that. And as similarly as with all our other patients, we believe in the autonomy of the patient. So we are collaborative partners in decision making. It's all about shared decision making. But your job is to make sure you have properly informed the patient. And we're going to spend a lot of time on that next week, being able to explain to the patient exactly what's going to happen. And then the patient makes the decision, and the patient also carries the responsibility for the decision. And that's very important. So with the gender affirming healthcare guidelines, just from that autonomy perspective, that was also very much including trans voices. So if we want to provide care for the trans community, their voices also needs to be included, and that autonomy, that respecting their autonomy, their beliefs and their requests. So when we speak about beneficence, these words, these big Latin words. So beneficence is this to do good, and this is when we are acting for the benefit of the patient. So this is basically whenever you are providing care to your patient that is hopefully going to make things better. So this pretty much talks mostly to the treatments that we give patients and the actions and interventions that we do take with our patients. It's defined as an act of charity, mercy, or kindness, and it has all got to do with doing good. And actually, with transgender people, the most simple thing to do good in a trans person's life is simply by respecting, validating, and affirming their identity. And as I've said quite often, when we think of affirmation, everybody thinks of hormones and surgeries, but actually it all boils down to just using their pronouns and their name and seeing them for who they are is actually the most important thing that you can do. It's the biggest thing that does good. So when I talk about gender affirmation, this includes using just the correct name, the pronouns, a sensitivity when you do history taken, an examination in terms of the language you use, making sure your healthcare facility's got some sort of plan in terms of bathrooms. What do you do in a ward, for example, if you're going to admit somebody with a broken leg, and it's a trans woman who's been on hormones for years? She's gone through a medical transition, and then you have to have a plan in terms of what you're going to do, where you're going to admit her. Accepting and validating their experience, what they tell you, regardless of your own views. And then, of course, hormones and other support forms part of that gender affirmation. So there's the benefits of gender affirmation is very clear, and you will often hear that people try and argue and fight about evidence, but actually there's lots of evidence, and we've got a very recent systematic review that's also come out in terms of the provision of gender-affirming hormones. And what we know is that it definitely improves adherence to HIV prevention and antiretrovirals. So if people know they're getting hormones at your clinic, they're more likely to come. It definitely improves quality of life. It improves social functioning. And we see a decrease in depression, anxiety symptoms, psychological distress, and an increased access to healthcare services. And these things have been very well described in a wide range of studies. The reason why the evidence thing comes up quite often is that people try and whip out the quality of evidence. And that's a difficult word, that quality of evidence, because everybody wants to see RCTs, right? So your double-blind controlled, randomized controlled trials. But it is physically impossible to do an RCT on gender-affirming hormones. If you give somebody hormones, it's going to be very clear who is getting the hormones and who's getting the placebo. So that's not really going to work. So a lot of the studies we have is useful because, for example, in America, we have examples of some states where patients can access gender affirmation, and you have some states where people can't access gender affirmation. So we can use those kinds of cross-sectional studies to give us an idea and give us this kind of information. But that often then will be said, oh, but it's not a RCT, so it doesn't count. So this is one of the challenges in terms of that we have when the evidence debate comes out. But the studies that we have is high quality. We've got good systematic reviews that gives us good information in terms of the benefits of gender affirming care. So non-maleficence, which is the do no harm section, is to avoid causing harm to others. And this is basically to do with if you are going to do an intervention, you have to be aware of the potential side effects or the potential complications of that treatment. So basically, this is where we're weighing up the potential good we can do, but also the potential harm we can do. So we always have to do that risk harm calculation for every patient that we see, and that's also relevant for our transgender patients. So obviously, if we're going to provide them with hormones, for example, we also have to be aware of the potential side effects or complications of those hormones. But the other thing to consider, and I'm going to cover these three little points, is that there's also a risk of not providing gender-affirming healthcare. So obviously there are always side effects and complications of any hormones that we give, but we also have to think a little bit about, well, what happens when we decide not to do it? And also, what is the harm of saying that we shouldn't be doing gender-affirming care to the transgender people as a community? So on that first point, the risk of not providing gender-affirming healthcare, and again, this is a lot of observational and cross-sectional studies on what happens in areas and in states, for example, like in the USA, where we are not providing gender-affirming healthcare, or even just in South Africa, there are lots of examples of areas where patients simply cannot access care. And then we definitely see a high risk of depression. And the big concern is the higher suicide risk, with a higher suicide risk within our transgender communities. And we mentioned earlier that one of the risks of not providing gender-affirming healthcare, and this includes just being affirming in a facility, is that we're seeing that transgender people are just not coming to facilities. They'll come very late, they'll try and not engage, and therefore we're not able to provide them with just normal healthcare and normal prevention services. So it's important to understand that limiting access to things like hormones, for example, can be seen harmful in and of itself, and that needs to be considered when we're talking about not doing harm. But let's just look at the ins and outs. So in terms of what happens when we give people hormones, we'll cover this in more detail next week. But for feminizing treatment, so when we give people estrogen, you can think contraception. It's very similar to giving people contraceptives or giving postmenopausal women hormones. And it's very similar to what we know about using estrogen in other settings. A little bit of headache. The one big worry is the increased risk of venous thrombosis. It's exactly the same as with contraception. But of course, very low risk, but we have to make our patients aware of this. And this only really becomes an issue if somebody has other risk factors that also puts them at risk of VTEs, or if they've had embolisms before, for example, or thrombosis before. Definitely, especially early on when one goes onto estrogen, it's a little bit like going through well, it's not a little bit, it's exactly like going through puberty. So one has the same mood changes as your body adjusts to the estrogen. And those can sometimes be can affect their mood and their underlying mental health. There's changes to sexual response cycle and libido. I'll talk quite a little bit about that next time. And then, of course, probably the biggest thing. I mean, all of these are similar to contraception. It's like, yeah. The one that needs the most discussion, for me, the one that's really the thing that needs to be that you properly have to inform consent on, is that, of course, if a trans woman has taken estrogen for a long time, she will eventually be infertile. With testosterone, acne, again, if you think about that puberty issue, so just like kids going through puberty, acne can be quite a bit of a bother. And we also know that men tend to have higher levels of cholesterol than women, so they actually end up having the same risk, trans man, as a cisgendered man would have, the same risk of hypertension as well. But an interesting sort of side effect is polycythemia. So that means too many red blood cells. The treatment is very easy. You just have to donate blood. It does not happen in most patients, but we do keep an eye on that to make sure that we can treat it. But it's all none of these are usually worrying as side effects and complications go. But again, same problem. If you've been on testosterone for many years as a trans man, there's a risk that you're going to end up being infertile. So there are side effects, but we cannot neglect this fact that exposure to endogenous hormones for transgender people is also not without is not without effects. But we have to look at what's in the best interests of our patients. And so this is where the informed consent becomes very important. This all needs to be discussed in terms of benefits versus risks. And then the third thing is just to consider the harm of actually saying, no, transgender people should not have access to gender affirmation because for whatever reasons. And that in itself increases the amount of stigmatization and minority stress that we are seeing within this population. So in a way, just by creating gender affirming services, we're also giving a very clear message that transgender people matter and that we want to provide assistance. By blocking these services or by not making these services available, and this very much has happened after the collapse in March of all the PEPFAR clinics. With all the clinics closing down, there's been very much an experience from the transgender community that they don't matter, that it's not important, that as healthcare, as a community, we do not care about their needs. And then our last principle is that of justice. And there are three types of justice under the ethical principles of justice. There's what we call distributive justice. This has to do with the amount of resources that are available. And it's pretty much from transgender person's point of view, it's being able, they should also have access as no matter what their financial scenario is, no matter where they live, they should be able to have access to the services that they need. And from a distributive view, hormones are pretty much very cheap. We'll talk about that next week. And one of the big things at the moment that there's very little access to is access to surgery. There's also the rights base, which is just about respecting the rights of our patients and ensuring that they do not get discriminated against. And the hate crimes bill is particularly being upgraded for that. And then from a legal point of view is this the fact that in our constitution, there is a right to actually change your gender marker, and we can assist our patients with this. And also hopefully eventually get the non-binary marker added as well. So in the world towards justice, what's actually happened for us as healthcare workers is the importance of what is called I don't even want to know how to say that. We're trying to take the pathology out of the terminology. So similar to homosexuality also used to be in the DSM as well as in the ICD as a diagnosis, and has obviously been removed. And what they've done in the DSM-5 that came out in 2013, gender identification disorder was changed to the word gender dysphoria. And the word in the ICD-11 that's come out in 2018 is currently being implemented in South Africa. I think this year they're rolling it out. Gender identity disorder was changed to gender incongruence. So it's important to note that we still have these terms available in the guidelines, in our um, what do you call textbooks. And that's useful if you are prescribing hormone therapy or doing surgery in the private practice. You will need an ICD code to be able to do that. The word gender dysphoria simply refers to the experience we have of having a mismatch between one's identity and between one's your biological sexual characteristics. And then actually in 2019, the WHO actually made a declaration in their assembly to just make it very clear that being trans or gender diverse is not a mental disorder. Similarly to being gay is not a mental disorder. It's part of human diversity. One of the challenges that we have seen is that in gender affirming healthcare is that although there's been a real move to providing care, all of the initial projects and services have been provided through the NGO sector. And that's partly been the disaster this year when that sector shut down. We're not going to talk a lot about transgender children, but this always brings a lot of emotions and a lot of stress to people. Very important to understand is that this is a very vulnerable population. It's a very complex population, and this needs a multidisciplinary team. It needs a lot of considerations around the identity formation and the ability of informed consent of that child. We need to also think in terms of sexual health, context, family, schools. This is not something that you are going to manage or deal with. And this needs to be looked after by professionals who are able to look at how to manage and help these children. A lot of children go through phases anyway where we're still trying to figure out what gender is. It's quite an interesting social construct, and there also has to be an understanding of that fluidity with gender as children are little. But there are now no doubt that there are some children from when they are very small have a very strong experience of being transgender, of being a transgender child, and finding it extremely difficult. The idea of going through, for example, if they are a trans boy and having to go through a female puberty can be extraordinarily traumatizing. So for a parent, if you're a parent who has a child that, for example, has come out as transgender or is at that gender fluid exploring phase, it's just important to understand that there are two different ways of approaching us. There's a gender affirming community that very much works with this multidisciplinary team, and they usually consist of pediatricians, pediatric endocrinologists, child psychiatrists, who has training and experience to decide what's going to be best for this child. There's a little bit of a narrative that as soon as we affirm a child and we listen to a child, that it's this one-stop shop towards hormones and surgery. Most certainly not happens. As a multidisciplinary team, we are very sensitive to the vulnerability of these children. But this needs to be surrounded by people who are experts in the field and who have actually worked with these children and knows how best to assist them. It's also very important to realize that there are obviously communities that sees transgender not as an illness or a confusion or an ideology. They would see that actually providing any affirmation of these children as being dangerous and a slippery slope towards hormones. They will bring interventions around conversions. So through therapy or other methods, there's very much an emphasis on trying to show these children that they are actually not transgendered. And there's very much a fear around social contagion. So there's also a fear not wanting a transgender children in your school because now they're going to infect other transgender children. But what's important to realize is there's very little expertise within these communities. So these are usually not usually people who are coming more from ideological groupings. They might be doctors or GPs, but they are certainly not working within multidisciplinary teams around trying to figure out what's well, they come from a viewpoint that does not recognize that there is such a thing as being transgender. Oh, difficult how to find one's language around this. What I'm trying to say with this is being able to understand which particular professional you are talking to, and that's quite important. So sometimes when parents start looking for help, they do not realize that there are these very two different paradigms of how we view what being transgender is. Is this a valid identity, and do we view human beings as having this extraordinary diversity? Or is there's also very much strong groupings that sees it as only a binary and that there is no place for being transgender or gender diverse within that binary? And of course, people have the autonomy to decide which community they will use to support them through this, but they do need to understand what the differences are between those communities, and where those communities are coming from. So as we've talked about ethical, what happens when we don't have ethics, and what happens when we don't follow these ethical principles? And we now have a classic example of this in what's happening within the USA. So in the USA, for example, they are trying to block all gender affirming healthcare for transgender people, certainly under 18. There's even when they've been fighting this in the courts, but Trump has been trying to move transgender, for example, a trans woman, to male prisons. They are blocking what do they calling woke topics. So woke is just another word for egalitarian. And what has been extremely concerning, and which has affected us directly, is that because the USA is signed up to this binary idea, they are now also trying to blackmail other countries in the world to follow their ideas. And I must say, it's been wonderful, the recent G20, to see how we as South Africa will not be bullied by the USA. But they've literally done this by telling NGOs that we will not fund you even for other projects that's not sexually and reproductive health related if you are providing any services within the sexual and reproductive health field. So they are trying to actually, and has actually forced NGOs to, I mean, it's a human rights issue if you suddenly withdraw care, and they've used economic blackmail to try and get that done. So just to look at what's happening in South Africa with gender affirming healthcare, and why this is such an ethical imperative. And very clearly, and certainly within the medical field, being transgender is not an illness or disorder, it's a diagnosis. Hormone therapy is a medical treatment. So obviously we need to think about medical interventions and have potential risk. And then there's always this question about why are we giving people who are not ill medicines? And I think you can compare this with other possible parallel programs that we have. So if we think of traditional circumcision, if we think of using hormone therapy in postmenopausal women, if we're thinking of contraception and sterilization, TOPs, cosmetic procedures, in all of these scenarios, there are a certain benefit to the person's life, which outweighs the possible risks of the intervention that one is doing. And so transgender people, we actually are treating a very healthy population usually, and providing them with affirmation, which improves their overall mental health. So the reason why we think this is an ethical imperative is because it contributes to the well-being of transgender people. And as an autonomous community, this is what they are asking for. The hormones themselves are cheap. They actually have relatively little side effects. Most effects are reversible. So what I also find interesting with people who want us to not give any hormones, usually, well, when you stop the hormones, most of the changes actually comes back. Big things that stay might be things like beards and breasts, which are not particularly harmful to health. But again, it's the patient that has to make the decision on these effects that they want to see. But unfortunately, they have to take the hormones for life if they want the effects to be continued. Our biggest long-term effect, as I've mentioned, and that you need as a healthcare worker need to make sure you've properly counseled your patient on, is around the risk to fertility. So they may not be able to have their own genetic children. And then everybody starts talking about regret. So that I find interesting, because regret is not actually something that you normally find under any of the ethical principles. So as medical doctors and as healthcare professionals and psychologists, you are not responsible for whether your patient is going to regret the decision they're going to make. And that's what all informed consent is about. So as informed consent, the important thing with informed consent is giving your patient enough information, handing it over to the patient, they make the decision, and if they regret it, that is their responsibility. You cannot take responsibility for regret. So, of course, in all medical information, there's always a risk of what we call detransition. So this is people who may take hormones for a while and then decide to stop taking hormones. But it's also important just to realize that regret is pretty much how human beings roll. It would be very strange if there wasn't people who at some stage decides, maybe the hormones is not working for them. These are some of the regret stats out there. So interestingly, about 40% of marriages have some regret and end in divorce before the age of 10 years. There's lots of big decisions we make that might not work out. So in no other medical procedures does potential regret play a role in decision making and care. So we don't usually take that into account. The rates for detransition, and that's one of the things we need more and more information on. But certainly within the facilities that we've worked and what we've seen within our gender affirming services in South Africa, the regret rate is very low. And a lot of people who do, they end up deciding not to take hormones any longer, quite often don't regret having had taken hormones, but sometimes it's not met the expectations that they've needed to have. Sometimes they realize actually life's not easier having gone through transition. There's lots of reasons why people might decide to stop the hormones. But this is not the reason to not give anybody hormones, because they might be the odd person that will regret it. So your duty is simply that of informed consent. So in conclusion, as a healthcare provider and as a human being, in the years to come, you will at some point provide care for a transgender or gender diverse person. So even if you're not ready yet to step completely into one of our clinics, you definitely are going to have people that's going to end up in your consulting room. And there are two ways in how you can view this person. You can either have that elitist perspective where you believe some people are more valuable than others, and then your transgender people we would consider to not have that right to opinion or to rights. And we are obviously very much advocating this gender affirming perspective, being able to see all human beings as having equal value and affirming the gender of that transgender person, to respect their autonomy. It benefits them and it does not harm them. Thank you very much. That's the presentation on the ethical side of it. I'm going to stop my slides and just see what's going on in the chat.
Madeleine,
Yes.
you may wish to look at Erica's question, which I have taken a stab at answering, but you may also have a view.